Welcome back. As I said at the start of the lecture on depression, we're going to look at 3 areas of psychiatric disorder: depression, psychotic behaviour and anxiety. So in the first session we talked about depression and we looked at the antidepressant drugs, and now what we're going to do is we're going to do a similar type of thing. We're going to look at 2 areas, anxiety and psychosis, and look at the medications to treat both of those. Anxiety is probably the most common psychiatric problem, and it affects about 1 in 7, about 14–15% of the population during their lifetime. Now it's characterised by a diffuse group of symptoms that people often say there's just that unease, an unpleasant, a vague feeling of apprehension. Can't always put their finger on exactly what it is though, and it's often accompanied by obvious signs of the autonomic nervous system being switched on: headache, palpitations, perspiration, gastric motility or the butterflies in your stomach, and a general feeling of restlessness. So there appears to be a sympathetic outflow here that's responsible for some of these things. Classified in a number of different ways. We've got phobic anxiety, anxiety disorders, OCD or obsessive compulsive, post-traumatic stress disorder or PTSD. They all come under the umbrella term of anxiety, and we're just going to look at it in that generic way. We're not going to look specifically at any one individual type of anxiety disorder. We're going to look at anxiety as a blanket coverage. Occasional anxiety is perfectly normal. You know, when you think about it, maybe before an exam, before a first date with someone, out waiting for a job interview, you might be a little bit anxious. But again, we're back into the realms of what we mentioned for depression. There is a normal continuum of human behaviour. And that normal continuum is that, yeah, we might feel a bit anxious, we might not, but when we do feel anxious, it shouldn't really stop us going about our daily business. It shouldn't be problematic to that extent. When we get to the pathological extreme, that's when it starts to interfere. So when you're thinking of things like phobias, panic disorders, OCD, for example, if you had such let's say you leave the house in the morning, and you might think, oh, I think I've left the, the oven on. I don't think I've locked the door. You go back and check. Once you've checked, you're fine. You go on your way. If that was if you like, pathological behaviour, extreme behaviour, you would go back. You would be away to your car. You'd be back again. You're back and forward. You could get to the point where you actually don't even want to leave the room. You're so concerned about what might have happened. And so people could not leave the house. Phobias like when people have been frightened of spiders, I mean, it probably wouldn't stop you being in the same house, but you do get people who are so afraid that they simply can't do something. Fear of flying, they can't get on an aeroplane without having a panic attack. It's that level of anxiety where it starts to interfere with your daily life. It starts to interfere with your ability to go about what you need to do. And that's when we're thinking about maybe having to treat this with pharmacological interventions that are anti-anxiolytics or anti-anxiety medications. Now, the possible causes involve 2 brain areas. The limbic system in general, but specifically the amygdala within that. The limbic system we've mentioned before. We said the limbic system was where the emotional disturbance came about to cause depression. So it's about the way we feel. That's the emotional part of the brain. And the amygdala is particularly involved in processing fear. And often the amygdala is what allows us to select a response to a situation based on a previous experience. So people have been afraid of the dentist. You go to the dentist, and once you're in the environment, that reminds you of when you were there before, and that's what makes you frightened. Or you've had some experience with people who are frightened of dogs. It might be that they've had a bad experience in the past. But it can also be a learned behaviour. You can pick up the fear of others, and it's their experience that you reflect on, and that can make you anxious or frightened as well. Now, loads of theories have been put forward. Too much serotonin, too much noradrenaline. But probably the big one is the deficiency in the limbic system of GABA neurotransmission. Now GABA, as we mentioned it before, is the major inhibitory neurotransmitter in the brain. So if you've got pathways that are under GABA influence, they will be dampened down in their firing. If GABA's not working properly, those pathways will be activated and fire at a higher level. You'll get more neuronal activation, more action potential being fired, and that could be what's responsible for the, if you like, the overstimulation of the area and the anxiety and the increased excitation that the person feels. Now GABA, gamma-aminobutyric acid, to give it its full name, works on two types of receptors, but it's thought that GABA-A receptor is the one that's involved in the mechanism of action of some of the anxiolytics. And probably the best known group of anxiolytics are the benzodiazepines, or the BDZs. For example, Valium is probably, again, in the past we've talked about drugs, we've always talked about what's the best known one. Valium is probably the best known anxiolytic drug. So Valium, to give it its proper name, is diazepam, but you've also got Librium, is also well known, it's chlordiazepoxide, lorazepam, temazepam, midazolam. All of these work by enhancing GABA neurotransmission. So when GABA binds to its receptor on a neuron, there is an influx of chloride ions, and chloride ions are negative ions. Now, if you think about an action potential in a neuron to fire, the rising part is down to the influx of sodium, which is positive, so you go from minus 70 millivolts up to plus 30. And that's the depolarization phase. Then you get the repolarization because potassium leaves the nerve cell. Now, if you're sitting at a level of minus 70, and instead of opening sodium channels, you open chloride channels, negative ions come in, and the membrane potential goes down the way. It becomes hyperpolarized. That neuron is now less likely to fire because you're moving that away from threshold and you're not going to get the action potential. That gives you decreased firing and therefore an inhibitory action on the neurons. So if the neurons are firing in an overstimulated way, and that's what's causing the anxiety, you're depressing the firing of those neurons. Now, it doesn't just work in that brain area. It's not just going to go to the limbic system and only affect there. That's what causes what they refer to as anxiolysis or anxiolytic function. But it's also inhibitory in other parts of the brain. And that's why these drugs have the side effects of inducing sleep or hypnotic. They cause sedation, and interestingly can also have an anticonvulsant property. Because somebody having seizures, that's thought to be down to either too much glutamate firing, which glutamate's the major excitatory, or not enough GABA. So if you enhance the GABA action, you will get an anxiolytic effect. And the way that they do that is, if you look at this diagram here, we're focusing on the benzodiazepine at the moment. These drugs over here are known as the hypnotic drugs. These are the ones used to treat sleep disorders. But we're focusing in on benzodiazepines at the moment. So, beside the GABA receptor, as we said, GABA comes along, works in its receptor, opens up a chloride channel. Chloride negative ions flood in, you get hyperpolarization, and the neuron won't fire. And that dampens down the overexcitation. If that's not working properly, and you give a benzodiazepine drug like Valium, it comes along and works on the binding, the receptor for that. And there's three different types of receptor, and benzodiazepines work at all three of them. When benzodiazepine binds to its own receptor, that enhances the action of this interaction. So although the GABA hasn't been working as well, the effect of GABA on the receptor is now boosted because of the interaction of these things here. So that goes out and knocks onto there and enhances, and that means that you get the extra chloride ions coming in as you would expect. So therefore, it enhances the natural GABA mechanisms, gives you and returns the inhibition to the level it should be to dampen down the anxiety. The thing to remember with these drugs is that they do have active metabolites, and that prolongs their half-life. That means they hang around in the system longer. So once you metabolize diazepam or chlordiazepoxide, they produce metabolites which are also anxiolytic agents. And that has to be borne in mind when you're thinking about your dosing strategy, the timing of the doses, that as the drug is being metabolized, the metabolites are also inducing an effect. They're not fatal when they're taken alone, these drugs, but they can be fatal when they're taken with alcohol. So if you're taking the maximum dose of these and you take a lot of alcohol with them, alcohol is also an inhibitor in the brain. And it can be that dual inhibition can actually cause fatal consequences. Although the alcohol interaction, etc., may involve more than just the GABA receptor. It's not that it's just both of them enhancing GABA action to cause an inhibition. There could be other mechanisms involved, but it's when the two come together you get the potential toxicity, and it can be fatal toxicity. So the adverse effects, because you've got the inhibitory action on the brain, you're going to get sedation. You're going to get difficulty coordinating your motor activity because the brain's depressed, and that can cause ataxia. You can get an inhibition of the memory systems, and that can cause anterograde amnesia. That's where new events are not transferred to your long-term memory. It can cause lightheadedness. Interestingly, in children, it can cause a paradoxical excitation rather than a sedation. And then in females, obviously, menstrual irregularities. So that has to be something that's borne in mind. Because if you had a female patient who was anxious because of some, if you like, some aspect of her life, you would need to explain to them that it can cause menstrual irregularities, can upset the frequency of the periods, and therefore they would be more at risk of a pregnancy because of the timing being knocked out. And that might be, something that they wouldn't want to happen if the anxiety was related to that. So, key thing about the anxiety then is it's thought to be coming about a variety of theories, but the one that's got the most credence because the drugs work fairly well is the GABA theory. That there's not enough GABA activity, so you're not getting as much chloride entry as you should, and the neurons are not being inhibited when they should be. That gives you the overexcitation, which leads to the anxiety. And the drugs that we give, the benzodiazepines, they work to enhance the action of the GABA. So benzodiazepines work on the benzodiazepine binding site. That's adjacent to the GABA receptor. That means that GABA now can interact with the GABA receptor better, and chloride comes in at a higher level. Moving on then to the psychotic disorders. Various disorders listed there. The one we are going to focus in on is schizophrenia. Schizophrenia is a relatively common one. About 1% of the population are affected. And it's thought to be due to a number of complex factors. A chemical imbalance, maybe developmental defects, there's a heredity, there's a genetic component, etc., etc. The key thing to point out is it's not caused by bad parenting or family traumas. There's no evidence to support that at all, although it's often put forward as a possibility. This is one where males and females are affected equally, but the signs, when the signs first appear, is different. It's more common to come on in young men between the ages of 18 and 25, whereas women it's more common 25 to 30. Now, what's interesting here is you can imagine when you see some of the symptoms here, you can see how they can be misunderstood as signs of puberty. And so you could see that as a child, a youth going through puberty could be starting to show signs that are the onset of schizophrenia because of the age group here, but they're not necessarily being identified. They don't have a split personality. They don't have that Jekyll and Hyde behaviour. And most patients, the big majority of them, are not violent, nor are they dangerous. The symptoms are really hard to pinpoint. They can be quite diverse and they can be quite non-specific. Common signs that come across though, people can be detached and communicative, not really interested in what's going on around about them, and that can lead to a real difficulty in maintaining a personal relationship. As I said, the early signs, particularly in males, are so vague that they can sometimes be confused with adolescent problems. And it can cause anxiety, depression, a sense of unease. They can become very suspicious of other people. That can lead to social withdrawal and a loss of concentration and moodiness. So you're probably able to go through there and think, okay, well, what things might be common in an adolescent? Well, yep. Yep. Yeah, possibly, definitely. You're ticking a lot of boxes here comparing this to adolescent behaviour, and that's why it can sometimes go unnoticed at the beginning. The symptoms are defined as positive and negative symptoms. Positive symptoms are those that are present but shouldn't be, and negative are those that are missing but should be. And then you've got, over and above that, you've also got the affective symptoms, which are to do with mood, emotion, how the person is feeling. So, just nicking back for a second, thinking of the positive symptoms, characteristics that are present but should be absent. The lack of communication, yeah, that shouldn't be there. We're a communicative species, that shouldn't be there. Absence of expected behaviour, social interaction is what we thrive on. If that's missing, that's one of the ones that should be there. There is also thought to be a genetic link, because there is evidence of schizophrenic behaviour running in families. But the research has indicated, that there's not a great deal of evidence at the moment as to exactly how much contribution it makes. It can be quite a difficult one, because if you get parents with, say, a parent and child, parents get schizophrenic, that could create an environment which could cause a problem for the child. And that might reflect in the way that the child then responds. So it could be genetic, but it could also be environmental, and it becomes quite difficult to separate them out. They've also done a lot of research into neurodevelopmental abnormalities, so things going wrong with brain development. And it has said that for at least a small subgroup or a small subpopulation, there is evidence to suggest that abnormalities or disturbances in the development of the brain in the womb or in the early stages of life may be responsible for schizophrenia. But as I said, in a small group of patients. Stress in itself is not a cause of schizophrenia, but it can be a trigger. So if a person is already, for want of a better word, predisposed to the condition, stress can bring on the symptoms and bring on the condition. One thing that's looked at, whenever you see a neuro problem, people are always looking for, is there a drug that we can use to treat here? Is there something we can give? So they're looking for chemical imbalance. And when they look at the chemical imbalance, in the same way as depression we saw serotonin and noradrenaline, anxiety we saw GABA, for this one we're looking at dopamine, although there may also be an involvement of serotonin. What we've got here is we've got the substantia nigra and the striatum. Sub-nig is substantia nigra, CS is corpus striatum. And you'll see that there are dopaminergic pathways going there. That's the nigrostriatal pathway. We've also got, this is also the midbrain. So this is sometimes referred to as the mesolimbic or the mesocortical pathways. And you'll see that there are dopamine ones going up from the ventral tegmental area up to the cortex. So we've got different pathways that fire dopamine as a neurotransmitter at the terminal. So schizophrenia is thought to be a hyperactivity in the mesolimbic and mesocortical pathways. And evidence to support that hyperactivity comes from the fact that if you give a drug to treat Parkinson's disease, now Parkinson's disease is caused by a low level of dopaminergic transmission in the nigrostriatal pathway. So you give a drug like L-Dopa and it elevates dopamine there, and it treats Parkinson's symptoms. However, it will also elevate levels of dopamine in both of these pathways. Now that would mean that in an individual who was not schizophrenic, these levels and pathways will be firing normally. You give L-Dopa, and suddenly these levels are now elevated, and that can bring on psychotic symptoms. Similarly, another piece of evidence says that the amphetamines are dopamine releasing, and they can induce psychotic behaviour. So that's the evidence that when you boost dopamine above normal, you can get psychotic behaviour. That leads us in then to the drugs. So if the dopamine hypothesis states that high levels of dopamine transmission in the mesolimbic and mesocortical pathways are responsible for the symptoms of schizophrenia. So what you need to do is block the action of dopamine, and you do this by giving a dopamine receptor antagonist. And the evidence would show that the affinity that the drug has for that receptor, for the dopamine receptor, correlates with the potency as an antipsychotic. So the better the affinity for the dopamine receptor, the better the block, the better the antipsychotic action. The drugs then are dopamine 2 antagonists, dopamine receptor blockers. And you've got the phenothiazines, and then you've got the aliphatic groups. Probably one of the best known is the one that's called Largactil. You've also got the group 2, which are the piperazine antipsychotics, and group 3, which are the piperidine. They're grouped according to their chemical structure. But what you find is, when you're looking at the side effects, group 1 have sedative side effects, but group 2 are more likely to have the extrapyramidal side effects. Now what does that mean? That's the motor side effects. In the same way as we said, when you boost dopamine to treat Parkinson's, you can get psychotic side effects. The opposite is also true. If you block the dopamine receptors, you're not just blocking them in the mesolimbic and the mesocortical areas, you're blocking them in the nigrostriatal. So you will get a downturn from normal. And that can induce Parkinson-like symptoms, or Parkinsonism with a small p. Not Parkinson's disease, which is a destruction of the neurons, but Parkinsonism, because you're blocking the dopamine action. But the group 2 and the group 3 chemical structure antipsychotics have lower extrapyramidal side effects, or higher, depending on the group. So if you wanted to keep the motor disturbances to a minimum, you would use a group 3. And also, that also has but that has an antiemetic action as well, because you're also affecting the systems within the vomiting centre, etc. One drug separate from those classes is butyrophenone, and it has the highest, if you like, incidence of the extrapyramidal effects. And that's haloperidol is one example of this. What you tend to find is the older drugs tend to have more of the extrapyramidal motor disturbances, and the newer drugs are more refined and have fewer of those side effects. Similar to the antidepressant stuff, there's a therapeutic delay. The dopamine levels return to normal because of the block. So you've got the pharmacological action, but it's weeks before you see a pathological improvement. And that could count in the same way as that kind of went against a little the serotonin theory, the monoamine theory for depression. It kind of goes against the dopamine hypothesis. The thing to watch out with these drugs, though, is they can cause sedation. They can also cause a dysphoria, you know, the opposite of euphoria, a disinterest and a blunted effect. But what's good about them is they can reduce the level of hallucinations and delusions that schizophrenic patients can experience. They tend not to have an action on the negative symptoms, and they tend not to cause euphoria. One key thing for a lot of centrally active medications is there's likely to be a dependency, and that's not a problem for the antipsychotics. You can get the psychomotor effects, as we mentioned, and they also have an antiemetic action, which can actually be a beneficial use. These drugs could almost be given as an antiemetic as well. And that's another thing to think about. So what we've seen in this lecture is we've looked at anxiety and the role of GABA, and we've looked at psychosis and the role of dopamine. So across the three topic areas, depression is serotonin or adrenaline being too low. Anxiety is the GABA effect not being high enough, and you boost that with the benzodiazepine. And then for psychotic behaviour, it's dopamine levels being too high, and you block that with your dopamine receptor antagonists. Thank you.